Thanks, Kristen. Just brief overview of the agenda. I only have a couple of updates for you as far as regional abatement is concerned, and sort of some stuff that we discussed on the previous call in terms of LGUs being notified of awards. And then Jason Rubenfeld is gonna talk to you about the OASAS transition to a single PRU. So, feel free, like I know there's some other litigating entities on here. If that content's not relevant to you, feel free to hop off. But we did want to make sure that we're making the most of our time with our LGU folks, and I guess especially those of you who operate as an OASAS provider. So with that being said, let me just pull up my numbers. I wanted to first say thank you. In terms of the reporting, we have 49 of 55 LGUs have successfully sent in their reports. I know Kristen is reaching back sometimes when we have questions or things don't look quite as they should. And so I also appreciate you being responsive to her and making those corrections and getting back to her. We have 15 of 21 OLEs who have reported. So that's for those of you doing the math, 6 LGUs need to report and 6 OLEs need to report. And we are waiting on 1 of the 5 cities. So we would really like this reporting to be complete by the end of this month. We have heard from some of you who are a little bit delayed in reporting, and we appreciate that you've had some other things that you're tending to. But if we could get these in by May 31st, and Kristen, of course, is going to be reaching out to those that we need a report back from, we would appreciate it. We really want to be able to talk about this reporting as complete, and also as when we begin to talk about numbers in terms of total dollars encumbered and total dollars spent, we really would like to be talking about the entire group. And Connie's gonna give us a little bit of update on the AG reporting.
Yeah, so good morning, everyone. Good to see you all where I can see you. So I did want to just jump in for a minute to actually one comment on what Lucia had just talked about in terms of reporting. So I just really want folks to remember that we're eager to get the reports from you, and then also that those reports are what trigger your next payment to be released. And we are very, very closely monitoring not only dollars that are, Charlotte, would you mind muting your line?
Oh,
Charlotte, or if Kristen, you could mute Charlotte's line, that would be great.
Yeah.
So
yeah,
in terms,
I'm just listening to.
Oh, thank you. Perfect. It's always good to catch that and get folks on mute before they say too much. So, in terms of reporting, it is what triggers the next payment. And as I was saying, we are closely monitoring the amount of money that we're making available and that's actually being spent. So one of the questions that folks, especially on the Opioid Settlement Fund Advisory Board, are particularly interested in is the amount of money that's actually been spent. And so you guys are critical in telling us through the reporting what amount has been spent. Of course, the amount that's been distributed through regional abatement is significant. It's a large amount of money, and we do want to be able to speak fully to what's happening with those dollars. So really eager for everyone to report. With regard to reporting, I just wanted to make folks aware that we are working with the Attorney General's office to obtain information on their distribution of funds. And so, as everyone's aware, we had been asking you as LGUs to report to us what you knew those AG distributions. And in a lot of instances, those dollars were going to, a member of the county administration, and you weren't aware of what was happening with those dollars. So I appreciate everyone's willingness to kind of do the best we could in terms of trying to get information. And I'm very happy to say that in working with the Attorney General's office, we're going to know who that person was, who the dollars were directed to, and we will have contacts. So we are going to implement reporting for that portion of OSF funds that were distributed, and we're going to reach out to those folks directly. So we're not going to be asking you to share what you know about those dollars. So I think that's fantastic, and it's just one less thing that we're going to be asking you about. So we do have to do a little bit of catch up in terms of that reporting with those entities, but I wanted to let you know that the wheels were in motion on that, and we will in future not have to ask you about those AG dollars. So that's a good thing, I think. And it'll help improve, reporting, right? If we're going directly to the source on that. So wanted to share that little bit of update with everybody.
And so then the last thing I just wanted to close the loop with you folks on is, and because last month we met as I joined your council meeting, and then we met just the day after. So I'm not sure which meeting we covered this in, but there was an ask of OASAS to inform the LGU when we did a notice of award. So we definitely heard that loud and clear. I think it nicely closes the loop in that when they apply for dollars, they're notifying you, right? So it makes sense that you would get notification in the event that they are awarded. So these award letters we're doing this on are not just for those competitive applications, but for when we award dollars as a direct contract. So many of you received emails yesterday where you were CC'd as the LGU person on 2 projects, one of them being the comprehensive integration, which is the third round of that. That is a competitive RFA, and that is for integrating OTP and outpatient providers. So that one was pretty straightforward. And then the other one where more of you were CC'd, I think, is the mood in jails. And so we did receive, some questions from LGU folks in terms of, are these new dollars or additive dollars? And the answer is yes. So anything that you've been doing in your location to date to assist with having to implement the directive of mood in jails, that's awesome. And these dollars are in addition to that. So hopefully that provides some clarity. We're going to be working closely with the providers. We're very, very early in this project, so they may not have a bunch of answers for you yet. We don't anticipate, that this will be active until later this year or early next year. So Connie and Jason are also here and can provide some additional details.
Thanks, Lucia. So I'm very glad to talk about this for a couple of reasons. So one, this is another example of where you guys gave us feedback and said, hey, we need to know what's happening with the funding. Can you please include us? And so you are CC'd on the award letters. And it will apply not just to something that's funded through OSF, right? This is across the board. We're going to be sure to include LGUs, so you're aware of dollars coming into your county. So I just want to shout out to us. We listened to your feedback and we incorporated it. So please continue to provide that feedback, because we do want to have, open communication, transparency. We want to be working really closely with all of you with regard to dollars and services happening in your county. And then the other point I wanted to make, so with regard to mood in jails, so we want to ensure that medication is available to individuals who are in correctional settings Our SOTA team worked very hard to be sure that there was a provider, an OTP, working with each of the jails across the state. So a lot of legwork went into that to ensure that methadone in particular was available to individuals in jails. And we did make an amount of money available to those providers who are serving the jails in order to ensure that they can meet that expectation. I also know that there's state aid dollars that goes into supporting services in jails. And I also know that some counties are using regional abatement funds or other funds to support services in jails. So this is a very complex situation. Also, adding to the complexity, multiple systems that are having to coordinate to ensure that those services are available. So I just wanted to let folks know that I am going to be working with Ravia Gaynor and the jails to understand the service delivery. I know that you all had already received a survey sent by OASAS with regard to what are the services and what is the funding that's going into the jail setting. So know that we haven't fully cracked that nut in terms of understanding what are the services, how are the dollars being used. So we're going to do some additional fact finding around that. So please stay tuned on that. I don't want to exhaust people in asking you the same questions about those services in jails over and over. However, we do want to be sure that we have a menu of services available to individuals in jails, and that we're able to support those, and certainly to the extent that we have funding to be able to ensure those services are being delivered. So know that there will be more discussion around services in jails to come. And I thank you in advance for your patience around that conversation. Brian, you have your hand up.
Yeah, I think Jason had his hand up first.
Oh, sorry. Okay, I didn't see that.
So just wanted to add quickly, the funding that is being made available, the priority is to ensure that methadone is being delivered and paid for. Because from our discussions with OTPs, jails, some of the LGUs, we found that some of the OTPs were not being paid for all or part of the services they were providing. So we want to make sure that first and foremost, that's covered, and then other wraparound services can be funded with that funding. But the priority is methadone.
Absolutely.
For this. All right. Thank you, Brian.
Yep, thanks. So Connie, you sort of touched on this, but to me, it's a little bit more complex in that without any discussion with the LGU, here's new funding, which says, how do you know I have that need? And in fact, I don't, because I already have other funds in the jail for the exact same purpose, both state aid and AG opioid funds. So I'm a little bit confused how we decided what funds are going into the jail and what ones I'm therefore going to pull back so that we aren't supplanting funds. So can you help me understand that? Because it doesn't seem like, other than yesterday's letter, I've had no communication about this.
So in terms of communication about the jail services, so in fact, Andrew Heck and his team did send out a survey to LGUs, and I want to say it was like 2 months ago or so, asking about services in jails and trying to understand from the LGU's perspective what was happening and what funding was being used. So there was that communication, Brian. I don't know if you've completed that survey or not. I can say that the response, as I recall, and Andrew can certainly correct me, as I recall, the response rate from LGUs was on the lower side. And to that, I also say that there had been other contacts from OASAS trying to understand the service delivery in jails and what was happening. So I also can see that there may be a sense of fatigue around answering questions and talking about this topic. In terms of identifying the need, so Brian, the SOTA office did work with providers and also in collaboration with Rabia and the jails to identify jails that were not receiving, or I shouldn't say this, I should say ensuring that there were OTPs collaborating with jails and that methadone in particular was being provided. So the SOTA office was in touch with providers and from providers was getting a sense. I also hear you saying where are the LGUs in that conversation. And I don't believe in the fall we had talked with LGUs about how dollars were being used. It did come up in conversation through reporting. Did we have any indication of OSF regional abatement dollars supporting services in jails? And I will say too, again, that, you know, we had sent out the survey. So I think that OASAS was trying to get organized around the need. We absolutely wanted to ensure that methadone was available. You know, could we have managed the whole thing better? I'm sure we probably could have. I think, again, as I said earlier, it's a complex situation in that there are a number of different players. There's the LGU, there's the jail, and the jail also using outside health care providers to deliver services, right? We're talking methadone. If we start talking about buprenorphine, there's another layer of service provision, as well as providers. And it's complicated because there's a number of funding streams bringing to bear on addressing the issue. So I can say to you, going forward, as I said, I'm going to be working with Rabia Gaynor to get a handle on this situation. I absolutely do want to know from an LGU's perspective what is happening. I think that the investment in the OTPs was just was to guarantee and ensure that methadone was available and that there was.
I would offer this, Connie, and I know others want to ask questions as well, so I apologize, but I think one of the lessons we learned from district, or at least I hope we learned from district, if money's on the table, people will raise their hands whether they need it or not, right? So asking the providers, do you need more money? I can't imagine many of them are going to say no. And they're not going to tell you what other money they're getting already for the same service. I just pulled up my local plan, and we give the local provider $186,000 just for enhanced jail services from opioid funds. So I can't imagine they need above and beyond that because the census isn't that high.
Right. And so important information. And I think too, what complicates this is that so the state aid we provide is for jail services, right? And that state aid has been in place for a few years. And the idea was, I believe, that those funds would be used to help in transitioning people from jail to community, making sure there's a warm handoff and that they're provided the services they need, which is slightly different than the mandate that medication be provided for folks with OUD, right? Because then we're talking about very specific service. We're talking about medication. We're talking about, a limited group of providers who can deliver on that. And so I think that when I look at it, I'm thinking about services in jails as the umbrella. I mean, of course, methadone, buprenorphine, naltrexone being available is part of that picture. And it's not just medication. It is services while in jail, as well as the warm handoff, that transition back to community. So it's a bigger picture, again, complicated. And we are going to take another shot at trying to understand fully what's happening. And I'll also say that, we want to do this information gathering so we do make wise investments in the service delivery and how we use those dollars. So know that we are looking to modify as needed our use of funds to ensure comprehensive service delivery for the jails. Other hands, other hands up.
Sure. Yeah, Dr. Aycock has a question.
Hi. Well, what I
Okay.
wanted to just say, how much I appreciate the fact that you all are CCing us in the emails for awards. It is appreciative. I would like to offer up a couple of suggestions and just maybe some insight too. And one of the thought processes, you all got a lot of the LGUs in the room now. It may be important going forward to continue these meetings to gather our feedback. Sometimes the surveys get lost in our emails, so it may be important to get us all in one room when we're able to. I know the conference does a great job with that, so that may be able to be some synergy there, so you can get some more in-depth feedback from us. So I would just offer that one suggestion. The other one I would like to just really highlight that what tends to happen is that when we are notified of an award and we are not a part of just that decision making, or at least providing feedback prior, then what it does essentially is it creates a splitting. And so then it becomes that people don't have to talk really to the LGU. They can directly talk to OASAS and the provider back and forth. And again, our task is to oversee and ensure services in our community. And most of those folks that are coming out of jail are coming back into our communities for services that are within our community. So I would just, offer up, just the importance of us as a team getting together. But the start of it, I appreciate the fact that we get the that you all are CCing us in, and I believe I got one for Monroe County. The other thing to just pay attention to is that um, what kind of data are you all collecting from the jails, or are you expecting the LGU to collect it? Because what I've heard in multiple conversations, not only within New York State, but also outside of New York State, is that some jails really don't want to have methadone. And so when you start looking at the population, most of them are taking the sublets, or they're doing, the Suboxone, because it helps to manage and control diversion of medication. So again, if you're connecting to methadone clinics, you want to ensure that the population actually is receiving it, because then the question would be, what are you doing with the funding? And then lastly, because I don't want to take up the whole time, is that what we're seeing, what I'm seeing and what I'm hearing from people also is that when people are leaving the jail, and a lot of times they're getting appearance tickets, and they're kind of recycling back and forth from jail in the community, but not staying long enough to be treated within the jail. Any thoughts around kind of like a step down secured, facility where some of these folks can get the support and need and help, and then, go ahead and go to their court appointments and come back, sort of like the day programs, you know what I'm saying, that they used to have, because these people are circling back and forth, and again, they have just appearance tickets, so they're staying one night and they're not getting treated medically for their dependency.
Thank you, Dr. Aycock. So it kind of taking them in order as presented, in terms of making sure, so great that folks are getting the CCs in terms of funding coming in. Again, when it comes to understanding the dollars that are being made available in the jails and the services, so you have my word, having heard you all today, as Rabia and I go forward to understand what is happening in counties and what's happening in terms of services in jails. You will be included in that conversation. And two, we've gone through a little bit of transition at OASAS with, and the survey was on the table. It took us some time to get it out. I think that, we're getting organized around this issue. And certainly this isn't one that's going to go away, right? I mean, there's going to be ongoing needs, and OASAS wants to get this right in terms of supporting the criminal justice system and ensuring that individuals in the correctional settings are getting the services they need. So absolutely, we will be having more conversations, whether it be as a group like this, or I don't know what the format will be that Rabia and I will hear from you and collect information from you, but we will. You have my word on that. And then in terms of data, so again, there's been a lot of discussion and a lot of work that's gone into trying to determine what is the best way of tracking individuals who are receiving treatment and medication, particularly methadone, in jails. How do we utilize our current client data system to collect that information? Also being aware that there are some other systems that exist that are used to track the dispensing and the use of methadone in particular. So our research and evaluation team, led by Dr. Ashley Jordan, is looking into that. We're having regular meetings to ensure that we are collecting the data. We do know who's receiving medication. And so importantly, that if individuals are receiving medication in jail, when they transition to community, they still are connected to a source for medication. So making sure that people have the support as they transition. So we are looking at that. And we also, OASAS is also engaged in some other research studies around access to medication and the utilization of methadone, and making sure that whether it be through MMUs or the OTPs, folks have access. So there's a lot happening around this. Again, I think we're just getting started in terms of trying to wrap our hands around it and ensure everything's covered. So you have my word that Dr. Aycock, you're going to hear from me. As are all the LGUs, right, around this issue. Other questions that folks have?
It doesn't look like it. So we are giving the rest of the time to Jason. Great.
All right, good morning, everyone. So let's talk a little bit about comprehensive outpatient services, where we are now, and our transition to the next step. So since this is my first time speaking within this group, I'm not going to make any assumptions on how much you know about comprehensive outpatient. So I'll explain a little bit what it is and what we've done so far. So traditionally, historically, outpatients and OTPs, even if they're run by the same organization, have either been in different locations, or even if they were in the same location, they were separate. So no mixing of staff, no mixing of groups, etc. About 2 years ago, we started phase one of the comprehensive outpatient integration, which gave access to programs who were co-located to integrate their H22 outpatients and H22 OTPs, in which all services provided: groups, individual sessions, assessments, intakes, medical, if you had mental health, if you had physical health, all services were available to both populations. Staffing can work with both populations. Use of facility was other than obviously the dosing area, was available to all populations. So physically, it was one program under one operating certificate. However, they still had two PRUs for OASAS purposes. So all service-wise, they were one program. Back in the room, unfortunately, they were still two programs for billing and reporting. So that was for co-located. That was also for programs who wanted to add an outpatient to their OTP, and programs who wanted to add an OTP to their outpatient. We did we provided some funding under SAPT for this. We had a lot of awardees there, and we increased our footprint throughout the state for OTPs. So we had a lot of new outpatient providers who added the OTPs, and many of them who through SAPT already open. I think we only have one or two who are just waiting for DEA approval. Obviously, we're working with the programs to improve how comprehensive outpatient worked. One of the complaints that we did receive was, which we anticipated, was there was a lot of work on the back end. because they had to differentiate on the back end who was who do I bill, where do I bill, where do I report. So phase two, which we anticipate starting in August, um, we will be putting both of those services under one PRU. So if you're a comprehensive outpatient program currently, you've integrated both your H22 outpatient and OTP, you will be moving to one PRU. It will be under a new program type, a comprehensive outpatient. So those programs will not be identified as H22 OTP or outpatient. They'll be H22 comprehensive outpatient programs. Some changes on our end had to be made. One of them was annual report, which we are able to get more information on whether a person's on methadone or not. That now is being done not just in the OTPs, but also in the outpatients because we needed it for in the comprehensive outpatient program. We needed to see if somebody went from an outpatient to the OTP or vice versa. And then for other reasons, which you know, I could also talk about, we decided it helps us better track services if we do an annual report, especially since even in outpatient programs, patients are staying much longer than they used to. So OTPs, we know people can stay for years. Outpatients used to be less than a year. Now we're seeing people stay in outpatients for more than a year. So tracking services, tracking data, can be very helpful. Another thing we instituted was an update to the 44. So in the 44, the past 44, we traditionally did not ask any information about whether you're on methadone or not. What we are doing now, especially because of the comprehensive outpatient programs, there's a question that whether you're on methadone dispensed, buprenorphine dispensed, and then we have other questions whether you're getting prescribed. So and we're also going to do trainings with the programs. In our language, dispense means they're in the OTP part. So when they're admitting that person and they're giving methadone or they're giving buprenorphine at the window, they would have that would mean they're in the OTP. One of the things that we looked at on our end is what happens if I come in to a comprehensive program and I then feel like I need methadone. So we were trying to figure out how do we track those people. So we're working on a form where we can track movement within a program. So it wouldn't be a transfer because they wouldn't be discharged. It's the same program. So we're working on a form where we just change that identifier to being methadone dispensing. So again, we're working with Prime on doing trainings. We're doing a lot of technical assistance. We have about a little under 3 months for the change, and providers have a lot of questions, but we're answering them. So there's the data part of it. There's the one PRU, which many of them are welcoming, if not most, because it will make it less confusing. And I think I'll stop there. I guess the other thing I'll bring up, obviously we've had a few OSF rounds of funding for this. As both Connie and Lucia stated, we did just release the awards yesterday for the latest round. and we plan on working with the providers to implement this. We meet with them regularly once a month. We do collaborations with all the programs who are working on comprehensive outpatient. We bring them all together so they can share, because some of them are new, some of them have been doing it 2 years. So, share their guidance, share their tips, share, their struggles. We found that was very helpful for the newer programs. So yeah, so I'll leave it at that. I'm happy to take any questions. All right, Katie.
Hi, thank you. With you saying that you are meeting with providers to discuss like how things are rolling out and that, I already have a provider in my correctional facility that provides everything but methadone. They're doing the groups and the other mat. Will the provider that it's not the provider that just got this award. Will they be coordinating together how this is going to work out in one of those meetings with you? Because in order to make this work as a very small rural county, they're going to have to work together. So I didn't know if that's something that you're discussing on your end.
So, just so I'm getting this right, so we're kind of transitioning back to working with the jails, right? That's your, that's
I
the
don't
question.
understand.
Yep.
So there's two things we're discussing today. There's the comprehensive outpatient, which is one program who has both OTP and OP services within one setting. And then there's the programs who are providing services to jails.
Yes. So being a very, very small rural area, our outpatient program is contracted to go in for my MAT services, but that is not who just got this funding. So I didn't know if they would then be coordinating that amongst themselves.
Yeah.
As
So,
well as with me.
Connie, you want to take that?
So, Katie, I mean, you're pointing out another one of the complexities with regard to this situation, right? And it's never ending. And so we are aware of the fact that there are providers who are already delivering services, and this is part of it, right? We wanted to ensure that the methadone was available. And so again, this is part of the work that Ruby and I are going to do in terms of identifying who are all the players, ensuring there is communication and awareness of who's doing what, right? Because
I just wondered if the two agencies would know.
Right, we will make
who
sure
got what.
that,
Okay.
like, get all the players at the table, make sure everyone knows who's doing what, so nobody's stepping on toes. And again, you point out, one of the complexities that we have to address, definitely. And you know what? It actually, there are some instances too where state aid may be going to two different providers to deliver different services, right? And then I hope this isn't true, and I don't know if it is or not. Then you might have an OTP that's delivering methadone, right? So let's hope there aren't as many as 3 providers working with jails, but that's what we need to untangle, figure out, and make sure everybody knows and is on the same page.
But are they going to be made aware, or is that something I should be doing on my end?
I think that OASAS OASAS needs to make sure everyone's aware. And I see that it's our responsibility to ensure communication and clarity around how we're supporting services in jails. So Rubia and I are gonna work on that.
I appreciate it. Thank you.
I have 2 questions, but I just wanted to offer up a suggestion to what you just said regarding OASAS notifying the providers. It will also be important for, because again, Katie's going to have to report that on the local service plan and looking at her community. So it's going to be important for the state to also communicate to providers that they need to be informing Katie and the LGU of what they're doing in the jails. Because again, those people are going to go back into her community and she's going to be trying to find locations for them and so forth. So I hear that you all are going to be communicating, but somehow emphasizing the LGU is just something as a suggestion. Jason, I wanted to go back to the comprehensive outpatient. I had 2 questions for you. My one question is this the comprehensive outpatient, and is that solely new programs? Or is this, or does all, because we have providers that are OT, OTP, as well as, we call it SUD. So that means they're going to have to combine their PRU.
So for right now, the PRU combination combining is only for programs who've already started the process of what we used to call integration. We're not using that because it gets confusing with OMH integration and DOH integration. So we're calling it comprehensive outpatient. But if the program had already decided we're going to integrate under one PRU, under two PRUs, but one OPSERT, those are the ones that now are going to have the one PRU. So it's not any program. It's specifically the ones that are comprehensive outpatient programs. So, and what makes you a comprehensive outpatient program? You're a co-located A22 OTP, A22 outpatient who went through a application process through the Bureau of Opioid Treatment. We approved you. Both of your A22 programs are now on one certificate. So if you don't meet that, if your program does not meet that criteria, they will not, even if they're co-located, they will not move forward to the next step. So we have a list of all the programs that we're working with who are already approved or they're in the process of integrating. So, we have 3 rounds of OSF, well, the third round now. Pretty much none of those are yet open. So we have a lot that are pending, but we also at the same time, I think we have about 27 integrated programs who we would have to move to the one PRU now.
So I just want to make sure I'm understanding. So
Yes.
what I'm hearing is that any previous integrated programs will have to convert to one PRU's kind of system. And
Yeah.
then any new ones would have to also be just one PRU system, is what
Yes.
I'm hearing, right? Okay, all right.
So this is,
So-
again, I just want to be very, very clear because there's a lot of integration going on in the world.
Right.
This is specifically for A22 OTP, A22 outpatient.
Yes, yep, that was very clear. So my 2 questions related to that then is the state doing anything to give the providers any financial assistance? Because this is going to be an administrative heavy lift on a lot of our programs with converting their systems. So that's one question. My second question, and then I'll go off so you can answer them. But my second question is, a lot of times I look at the New York State OASAS data system where we upload a variety of different PRU data information providers, goes into the system. So how is it going to affect those numbers? Now, because for a while it's been 2 separate numbers, now it's going to be one. So I'm just curious, and maybe you don't know right now, maybe that's just something to think about in the future, but that information is helpful at times. So just curious to see how that will be impacted. Thank you.
So first question, most of our providers who have integrated or are integrating have been provided some funding. So they can use that funding to update their EHR if they still have the money available. For those that don't, that's a good point that we can talk internally to see, any thoughts on that and how we could support. The second question may or may not answer your question. So when they're integrating to one PRU, they're now going to be giving a new PRU. So those 2 PRUs they already have are going to be gone, and then they're going to get a new PRU.
Thank you. So eventually is you guys are gonna kind of filter out the two PRU data collection.
Yeah.
And it will
Yeah.
just be one. Okay, thank you.
Correct. Any more
Other
questions?
questions?
We're all gonna, any more questions? Because we're definitely happy to give you 12 minutes of your time back.
Yeah. One last thing I will share, and I know Pat Lincourt's, she says this all the time when we're talking about comprehensive outpatient. This is the future, having all services. Well, it's the present as well, but having all services in one program. We're not there now, but our hope is one day to have like full one-stop shopping of mental health, physical health, OTP, outpatient. So if you have sorry, if you have programs who are co-located already, but and aren't doing this, I talk to them and urge them to get on board. And also, again, I don't know if, when, how, if we do have funding for this again. I do highly recommend that you push your programs to do this, because one day it may become more of a you need to do this, and we may not have funding to do this at that time. So just something to keep in mind.
Yes, so I'm gonna temper that just a little bit, and say that, and I appreciate Jason not wanting to promise there's dollars, so thank you, right? We never
I
want to
never
promise.
promised. I
That's,
never
no, that's
promised.
appropriate. But we do want to convey that this is a priority. This is a high priority for the agency. And we do see that, as Jason said, like, this is the future, and this is what we want. We want to ensure that there is, medication accessible to folks, regardless of the door that they walk through. All three types of medication, ideally, right, to treat OUD. And so we do have funding available to support this effort. We, as we had mentioned earlier, just issued those award letters, and it's the third round of funding that we've provided. And there will be additional iterations, and we will continue to make dollars available. I completely agree with Jason in his saying that it is advisable that, in talking with your providers in your county, that you encourage them and support them taking advantage of having those dollars to be able to complete this integration. So really, we want to bring everybody along on this one.
And especially since we do have the LGUs on here, we still are looking at areas that don't have any services. Again, we know that most counties have an outpatient provider. I think pretty much all, some of them are the county providing those services. But if it's not, I'm not gonna say it's easy, but when you already have that footprint, it's easier to open a comprehensive program, just adding the dosing part, since you already have the services. So, and myself and my team, we will walk you through the whole process. So if it's a scary thought of opening an OTP, we walk you through the whole process. We hold your hand the whole way. um, and we did learn from SAPT to OSF. We've increased the funding significantly to make sure that it really covers pretty much everything, soup to nuts, in opening the program.
Sharon, you had a question? Can take yourself off mute.
Hi, thanks so much. Just a really quick question. We've been trying really hard to roll out a new OTP here in Cortland County. And oh my gosh, every single level of this has been exhausting, Jason. So any support you can offer to this poor provider, they're stuck at the DEA level right now. But also at our recent, cross communication integrated care is something we're really working on all the time with, OASAS, OMH, substance use and co-occurring mental health. But we came across a very unusual situation at a community meeting where we're now understanding that so we're trying to get naloxone out into the community and really train everybody to use it. But we came across kind of a absolute block where OPWDD local residents has been told that their staff are not allowed to have Narcan, or not allowed to get trained on Narcan. Just questioning, is this like a thing that we're not aware of? We just had this meeting in the last 2 days. It came up, and a bunch of the local Narcan, they're trying to really get Narcan out with our healing community study. Is this an OPWDD thing? Is OASAS talking with OPWDD about this? Has anybody else experienced it as their OTP providers are trying to kind of get out there? Kind of surprised us.
So, and it's surprising me to hear this. And so part of the reason why I'm surprised, Sharon, is because we are collaborating with, other state agencies. I have not heard that is, the position that OPWDD has taken. I absolutely will take that back, and we will look into that and address that. We
No
actually,
worries. And I don't want to like belay the point. Candace, do you mind if I just like add you to the email when I reach out to OPWDD about it, just to kind of get quick communication to solve what I
Sure.
hope is just a misunderstanding?
Sure,
Oh,
absolutely.
thank you.
Yep. Yeah, I mean, and from OASIS's perspective, and certainly, starting with the state opioid response grant, I mean, naloxone saturation is the ideal state, right? We want to ensure that, everyone, and when I say everyone, I mean everyone in New York State carries naloxone, and have really done a lot of work and invested a lot of dollars in ensuring that naloxone is available to the public, and again, in collaboration with our sister agencies. So we absolutely will follow up on that. And just a plug for the portal, just a reminder to everybody, if you have any organizations or entities, not necessarily only SUD entities within your county, that don't have access to naloxone, please know that naloxone can be ordered by individuals and organizations using our portal. So going to the OASAS webpage, if you follow the links to the harm reduction supplies, folks are able to order and have naloxone delivered to them, as well as test strips, fentanyl and xylazine test strips.
Yeah. And regarding to your first point, Sharon, we're working with them the best we can. I'm actually visiting them today in Ithaca, Deborah program.
Thank you so much. I know they have a long running program in Ithaca. That's why we thought it was so strange that this DEA situation came up as they're trying to open it in Cortland. And it's literally like, I don't know, 5 months now stuck at the DEA level. And I'm not sure if they've shared with you that it's simply
Oh,
because
they
the
shared.
name doesn't fit on the DEA
Oh.
form. We're like, no, that can't be the holdup for over 4 months.
Yes,
Thank
it
you,
is.
Jason. I really hope that we can get a resolution. Appreciate
Me
it.
too. All right. Anyone else?
And I just popped the harm reduction link in the chat, as Connie was saying this. And if you have providers who need to be set up with a provider account, then who aren't already set up with a provider account, I'll just also.
So I know, thank you, Lucia, for putting that in the chat. And I just want to say, I really do appreciate the time coming together with all of you to talk about not just regional abatement, but the so many initiatives that are underway and the work that we're doing, and reminding us and of the importance of our coordinating our work and collaborating together. on all that is happening. So I appreciate the reminder that you all give me when we have these meetings. And I do believe, actually, I don't know what's on deck for next month's meeting in terms of who our guest speaker will be. Thank you, Jason, for attending today and talking about the comprehensive outpatient plan. As always, guys, please feel free to reach out to the OASAS project management mailbox with regard to OSF and regional abatement. Certainly when it comes to planning, you are in the hands of Andrew Heck. You're very well in the very competent hands of Andrew Heck around planning. And we will talk to you soon. Get those reports in, please, if folks haven't gotten their reports submitted. Looking to get those by the end of May. So thanks so much. I realize we're running over or coming close. Everybody have a great day. Bye-bye.